Lima is a lactation consultant and a registered dietitian nutritionist. She trained at UNC School of Global Public Health, becoming an international board certified lactation consultant in 2017. She graduated with her PhD in nutritional biochemistry from NC State University in May 2018. In addition to owning and operating her website, Hope Feeds Babies, Hope is employed full-time at Winthrop University in the Department of Human Nutrition. Dr. Lima, you now have the floor. We look forward to hearing your presentation.
Thanks so much. I'm really excited to be here today. As Zara mentioned, I also graduated from NC State, so I feel a little bit time warp, although we were in person when I was there. COVID has obviously changed everything. Dr. Goodell, when she reached out to see if I would share a little bit about the research that I'm doing, I was really excited because I haven't really even been back because COVID hit so soon after I left. So I am employed full-time now at Winthrop University. I am an assistant professor and I've moved into the position of graduate director because we have very small departments. There's not a lot of us to choose from. And then I also oversee the certificate in medical lactation, which is similar to what NC State has with their lactation education courses with Dr. Fogelman. So a little bit about my background. My PhD was in nutritional biochemistry, similar to what every one of you is going through. But my focus when I did my dissertation was looking at the composition of human milk and how it was impacted by different pasteurization processes. So it was really interesting, especially now being gone, being in a department that had such great food science resources, because I was able to kind of cross over with that and into pasteurization and seeing there was a lot of excellent resources there for, you know, doing things that other universities maybe couldn't have done. I'm a lactation consultant and a registered dietitian. That's really where my interest for research kind of overlaps. I like to look at how maternal intake drives clinical outcomes in lactation, things like galactagogues, food restriction. I have done some work with allergic disorders and exclusively breastfed infants because that's something we see a lot in a clinical setting. And then obviously I work at university, so I'm interested in educational practices, both in the university setting and with supporting parents. So that is what my research kind of looks at. And Dr. Goodell mentioned that not all of you would necessarily have a background in lactation. So I have just a little introduction of things that that I'd like you to know before we talk generally about my research. So our breastfeeding recommendations in the US and globally for initiation when the baby first breastfeeds is within 1 hour of birth. And both in the United States and globally, they recommend exclusive breastfeeding. So no other solids, no other liquids for the first 6 months of life. Where the US recommendations and the global health organizations differ is for the duration or how long a baby should be breastfed or child. In the US, they say 1 year or as long as mutually desired, but really that translates clinically to a lot of families getting the message of, well, if you make it to 1 year, then it's time to wean. Where the global health organizations recommend 2 years and beyond. And really, this is important for food security for a lot of those populations as well, and reducing infant mortality. Whoops. So there's a lot of different lactation credentials, and I took this from one of my peers on who this went around on social media. And so the lactation practices and, you know, referral practices of primary care providers, which is something we'll talk about today, are really kind of jumbled because there's so many different things that you can do to get education in lactation, and all of them are so necessary and helpful in getting parents where they want to be. But it makes confusion among the people who are giving point of contact care. So OBGYNs or pediatricians mainly. So my first area of research that's kind of evolved since I came here is lactation practices in primary care settings. I had a thesis student come through who was really interested in this, and that's been a focus over the last few years. When we looked at the background of what was going on, we really wanted to look at evidence-based barriers. Why aren't parents breastfeeding for as long as recommendations are saying, or, what are the problems that they're facing? So things like actual or perceived low milk supply, or their baby not getting enough to eat, having difficulty with the physical act of breastfeeding, they're not gaining weight well. But one of the things that this student was really interested in that we found was the inconsistent or lack of professional support. So that kind of really echoes a million different credentials that exist in lactation. How do you get good support if you don't even know where to go? So we really dove into because the primary care providers are the consistent point of contact for these families, we went and looked at some residency didactic curriculum, some breastfeeding literacy research, and some perceived clinical barriers from the provider perspective. And we came up with something that was supposed to provide support paths. So we have the 10 steps of successful breastfeeding. This is a really big movement in hospitals. And so we focused in on how we have these great 10 steps. They exist in the hospital, and then parents leave. How do we keep adding steps afterwards to make sure that things are getting supported after we leave the bottle? Because we see here at step 10, discharge, and then, it's primary care providers that really are getting consistent follow-up with these families. So this is the kind of spectrum that we were moving upon, was that hospitals are becoming baby friendly, so they're getting better support. That means they're going to leave and they're going to be asking questions to their physicians when they get there, because now they didn't just deliver in the hospital and get handed a baby and say, hey, good luck. They actually are getting education and they're getting support. And so now they know to ask questions when they go to their primary care providers. But if they're not well prepared, that could lead to that inadequate support. And if they don't know where to refer to. So we developed a survey, and you guys have two resident experts that I learned from survey development from Dr. Goodell and Dr. Cook. And we looked at really what are practices that are happening in primary care settings? How are people giving support? What are the areas they feel confident with? What are the areas that they feel they're lacking in? What are their referral practices? And so we ended up with our rough draft survey of 49 questions. And we're asking retrospectively what they experienced, not what are their plans to change these things, but retrospectively, what has their practice been? And we focused in on time with encounters, practices with lactation support and medical management, and referrals. We did go through content and face validation for this survey. Content validation is when we're talking to professionals in the field and asking them to rank questions from irrelevant to relevant, inviting them to give open feedback if they're feeling it's irrelevant or they feel it's relevant and it's not worded properly. And we asked 13 professionals, received feedback from 7. The minimum that they recommend in the literature is around 5. So we hit that, but we didn't get all 13 back. We figured that we wouldn't though, but we did, in reading through all the qualitative feedback, we did reach saturation with what they were saying. Like it started to be, by the time we're getting to the 7th person's feedback, we're hearing the same things over and over, which is a good thing to have when you're going through this process. So we actually ended up expanding the survey because they wanted clarification of specific. There were terms that they felt like were overlapping, and they wanted us to tease those out and give definitions. So what did we mean by lactation education versus lactation support versus lactation medical management? And that was where the survey grew by a couple of questions, because we pulled those 3 terms out and defined them and then asked specific questions about them. During face validation, we were distributing to professionals with appropriate research understanding. We did receive feedback from 3 professionals. And obviously my train of thought left my head right there because now I'm seeing received enough feedback too. We've received enough feedback that we were able to increase our questions from 56 to 57. And we performed on this last step, performed our content validity index and had a 0.95 with the whole tool and eliminated any questions that came back at below a 0.86. So the way we calculate that is just a proportion, what percentage of the feedback was in agreement with each other. And if there's someone that disagrees, we start calculating a proportion of agree to disagree. So we were able to parse that out and the whole tool came back at a 0.95, which above a 0.86 is considered to be in agreement amongst the professionals that reviewed it. So we then moved to distributing our survey, and we got 132 survey respondents, but this student, we have a bunch of data that's not been analyzed yet, but this student was really interested in clinical primary care. So we excluded 85 due to an exclusive use of an ancillary credential. So registered dietitians, lactation consultants, and only included those with if they were a nurse practitioner, an OBGYN, a midwife, and you can see on the right-hand side the characteristics of those that we included. Really people that would be employed full-time in a primary care setting and giving care on a day-to-day basis. We did want to have a mix of inpatient and outpatient was fine, but because primary care occurs mainly in outpatient settings, we eliminated 7 respondents because they only worked in a hospital. So they're only seeing high-risk infants or first couple of days of life. So we ended up with a population of 40 at the end, which is on the smaller side. We'd like to redeploy this at some point, but thesis students only stay for 2 years, so that limits us in some regards. Some of the main findings we had first was that providers are talking about feeding, which is awesome because it didn't used to be something that people talked about. So 69% of our primary care providers were saying that they spoke to clients, but it was less than 10 minutes per prenatal encounter. So this is primarily coming from an OB perspective because a pediatrician wouldn't be seeing them prenatally. 35% always brought this up, and 38% most of the time brought up feeding during their postpartum encounters. So more than half, almost 70%, or actually 73%, are almost always talking about this during postpartum encounters. So once the baby arrives, which is something that came out in the findings of this, is we know in an evidence-based manner that bringing up infant feeding before the baby comes is far more likely to have an outcome where the parent meets their goals than just bringing it up postnatally. So there was one thing that we noticed a discrepancy in care. During the postpartum period, though, it was a good sign that more than half of providers spoke about feeding for more than 15 minutes. So this is a main focus if you think about the amount of time that primary care providers spend with their clients, anywhere between 5 minutes popping in and out and 20 minutes. Generally, if greater than 15 minutes is being spent talking about this, that's a good chunk of their visit when they're with a doctor. And the most frequent request from a patient was information on breastfeeding. So not as many patients are asking about formula feeding or mixed feeding, but they're specifically bringing up questions about troubles with breastfeeding. We did also find that the reasons for referral were very much inside of what we felt or hypothesized going in was part of things that we felt primary care providers should be able to give some amount of counseling for. So you can see that 70% of people that responded say they give referrals because the baby's not gaining weight well. 83% because they're having difficult latching. difficulty latching, maternal anxiety, low milk supply. So all things that they very likely could have the education and give support for, but again, they're only spending a certain amount of time. So they're ending up referring out for these different practices. And then really interestingly, those we had 11 respondents that had an MD or an NP or an RN and an IBCLC credential, which is probably some bias in the population that decided to click on our survey and take it because they think breastfeeding is important. Where the people that had IBCLCs are referring out at a higher rate. So could potentially speak to knowing what an IBCLC can do, what lactation support looks like. So there might be some missed information there for those that don't have that lactation background. We also, and I think this table is biased because of the people who clicked on the survey, feel like you get selection bias when they're participating if they feel like breastfeeding is important. So they were all feeling really prepared to educate, comfortable to educate, prepared to provide that support in medical management. So that was the definition we gave for that, is giving something hands-on, whether you're prescribing something, you're asking them to watch them breastfeed. Those were some of the examples we gave. You can see over 70% in all of these, they're feeling like they can do these things, but they're referring out for them. So time is definitely a barrier in this population. So they think that lactation care is a part of their role. 56% are referring out to lactation professionals. So really what our survey supports is an integrated care model. They know that it should be provided in that primary care setting. It is part of their role and what they're doing, but they're not able to do it in their space. And once we have clients that are leaving this space, if they're going to follow up, if they're going to call that person, depending on what the referral model looks like, you really could lose lactation support in between that. If this is one more step that a parent has to do when they leave, it's much less likely to occur versus, well, we have a lactation professional here on staff. Let's move you over into that room. I have seen pediatric models where every postpartum pediatric visit, while the dyad is still breastfeeding, automatically at every visit is going to lactation consultant directly after seeing the pediatrician. So there are models that work or that are being proposed and that are in, out in the world, but they aren't the norm. So that was some of the more survey-based research that I've been working on. And then I have continued my bench research since I've come to Winthrop, which is what my main focus in my dissertation was. So as I mentioned, I was interested in donor milk. And I really am interested in inpatient settings for donor milk, what we're doing in NICUs, because that's the main recipient of a donor milk bank's milk. So one of the things that we've been working on recently is once we thought, right now the recommendation is that once you thaw human milk, and this is across the board, inpatient, outpatient, once you thaw human milk, if you don't feed it in a certain amount of time, you have to throw it in the trash. And this is at home too. Parents, once they thaw, they're recommended not more than 5 days in the fridge before they discard it. And really, with all that we know about how alive human milk is, all of the bioactive components, my brain automatically is like, why are we throwing out human milk if it hasn't been used? What is there actually like an evidence-based reason? Because in the literature, there's not, especially for pasteurized milk, some of the concern with raw milk is the potential for bacterial growth, though we have some small studies that show that bacterial load actually decreases over the first couple of days in the fridge. Still, I know there's the concern with bacteria. So especially with pasteurized milk where there's already no bacteria, we screen for it. There's no bacteria left in the milk when we send it. So we got a sample of milk containers that had been pasteurized from WakeMed Mother's Milk Bank, and we thawed them, measured everything, then refroze it over a week's time, and did this 4 times. So we went around the circle a lot of times, like, what would you do if you were in a small rural hospital and this is, you have a limited amount of milk? Why would you throw that in the trash if there's nothing wrong with it? So we were measuring we started with our macronutrients, lactose, fat, protein, and then bacteria, because those are going to be the main things. Are the babies still getting the same amount of calories? And are they at any increased risk for any type of bacterial concern with that milk? And then depending on the results from this, we had plans to move into more micronutrient and bioactive analysis, but we're not quite there yet. So our total fat was measured using a hematocrit from EKF Diagnostics. This has been validated for even bedside use in hospitals, though I don't know that I totally agree with that practice. So really quick and easy way, it spins the milk down. You have a cream layer, and based on the proportion, it is fairly accurate in estimating both total fat and total calories per ounce for that milk. We measured total protein using a BCA assay from Thermo Fisher. It's a colorimetric assay that's read on a microplate spectrophotometer. And then for total lactose, we're using an enzymatic lactose ELISA that we essentially are digesting everything into galactose. So the reading is actually total galactose in the milk. For our bacteria, we are using Petri films. We're doing a total aerobic. So anything that can survive either in an aerobic or oxygenated environment, and we would have some facultative bacteria that would grow there as well. We look at coliform and Staph aureus and E. coli. So those are the ones we're focusing in on because those are a concern with this population. We have some data that's come out of that. This stuff is not published yet, so please don't photograph/share all of this. But protein, what we're seeing at baseline and through the freeze thaw cycles is that it's clinically not going to be different. We already know that human milk composition changes between feedings, during feeding times, day to day, between parents. But clinically, this is all right around where we would expect it, between 14 and 16 grams per liter of protein. So fairly stable here with protein over the freeze thaw cycles. And I guess I should have mentioned in the methodology, we're being very careful with this. If we were in a setting where we'd be preparing feeds for a NICU kid, you would want it to be sterile. So we were in appropriate PPE. We were using a hood that was helping to keep the sterile environment, and gloves, and the students were trained on sterile techniques. So minimizing any contamination risks, which would have to go along with the practices in the hospital. And hopefully they're already doing that in their feeding rooms, but I don't know every hospital. For hematocrit readings, what we were seeing is that the hematocrit percentage actually changed a bit, and it was correlated with the lipid content, which just makes sense. Honestly, I feel like a big part of this is where when you freeze and thaw milk, cream starts to settle and separate out. So depending on how well you're mixing the samples before you take it's a tiny little tube that we're taking, you could see some variation between samples measuring the fat. But really great to see was that the total calories per ounce, we saw significance in this statistically, but clinically, this would not. They were all floating right around 20 calories per ounce, which is what we guesstimate human milk to be at when we do calculations in a NICU setting. So even though we saw some slight variations between protein, fat, really the calories are staying consistent. And a lot of these kiddos are on a fortifier anyways for those macronutrients. So we're not seeing big enough swings that it would cause an issue with using this as a feeding method. We're waiting on we're actually halfway through our bacteria freeze thaw. And right now we aren't seeing any growth. We just don't have the entirety of that completed, which is why there's no table for you. And then lactose is up next after that's finished. So we have an undergrad that's very diligently working through these on her Tuesdays when she doesn't have class in the afternoon each week. So those things are forthcoming. And really what we're feeling is that right now, if you're using appropriate conditions for feeding preparation, that you shouldn't have an issue with refreezing if it wasn't all used, but it does need to have appropriate PPE, using sterile conditions, making sure we're under a hood. So potentially some, especially for those lower resource hospitals, that this is a big thing for them to be pulling donor milk into their spaces. We can potentially have some change in what the recommendations are. So that's what we are really actively working on right now. I have which is kind of what happens when you're interested in research. I feel like I think of ideas for research way faster than you can do experiments. And there's a whole bunch of things that are in development and floating around. I have a dietetic internship group working on diagnosis and management of non-IgE mediated allergic disorders in infants and young children, really interested in breastfed infants. So when you have a baby that has milk soy protein intolerance or allergy, right now there's not, well, in my opinion, clinically, anecdotally, which is why we're doing the study, a lot of pediatricians don't actually do any step-by-step analysis of, does this kid actually have an allergic disorder? They're just jumping straight to go dairy free, go soy free, and then parents call me and they're like, I'm on such a restricted diet, this is miserable, and I don't want to breastfeed because I'm having to avoid everything. And so I started digging around, and really shows that such a high percentage of babies have like very microscopic blood in their stool. And unless we're seeing really large bloody stools from some sort of allergic proctocolitis in their GI tract, there's not really that large of a risk of keeping, unless the baby's really uncomfortable. So, you know, thinking about what's going on and looking at the full picture rather than jumping straight to like a quick fix. We also know in pediatric allergies that many babies outgrow these things. And so the mom shouldn't also be on this for like 10 months. And that's a lot of times I'm getting calls like, I've been doing this for 6 months. And really pediatric allergy recommendations are to reintroduce after about 4 weeks to see if the removal of that load could bring the baby back down to baseline. We're working on a project that looks at practices and perceptions of galactagogue use in parents with diagnosed or perceived low milk supply, because we just don't have a lot of information about that. So my clinical brain is like, well, then let's find some information about it. We're looking at expanding lactation education in a university setting. What are gaps in the current modalities of training? How do we improve that? And how do we get quality care providers that have been trained well on the other side? And then detection of bovine protein allergens, that kind of pairs with our survey with diagnosis and management of the non-IgE mediated allergic disorders, is how long do these things actually show up? If you do an elimination diet and then add something back in, does it change the amount that is passed into the milk? And association with infant GI distress signs and symptoms from a parent perspective. So we have all these things that are developing. And that's where my lab is. I spoke way faster than I thought I would, so I'm a little bit early. So does anybody have any questions?
Thank you, Dr. Lima, for a wonderful presentation. Yes, as you said, we can move on to the question and answer portion of the seminar. So if anyone has any questions, feel free to unmute yourself or leave a question in the chat box and I'll read them out. So actually, Dr. Singletary has a question. She says, do you have plans to replicate with donor milk in non-PPE setting, similar to what it would look like in a newborn nursery?
Yeah, now that we saw what we saw, I would love to do that. And I'd also love to do it with raw milk. And I know Dr. Fogelman had a study that came out that looked at even babies that fed from the bottle, and you know, there's not that much of a risk of putting it back. We saw bacterial loads decreasing over days. So I honestly, and actually Dr. Fogelman's study that got published on that was like, whoa, I mean, this is very little control. We literally fed it to the baby and then put it back in the fridge. So why would this other modality be a conflict? So I am really interested to do it in a non-PPE setting and for raw milk, because why are we going to keep throwing out all the milk that could be used for other things? But yeah, only so many hands in, as you guys know.
It'll be interesting to see it. Sorry, Zara, go ahead.
Oh no, sorry, you continue.
Just saying, I'm looking forward to seeing that if you do get some capacity to do that. Because I think there's a lot of waste, like you said, in that application.
Yeah. And now that we have a study design for one, it would be, I mean, and a student that's trained, I'm trying to convince her to stay for her thesis. So, you know, we'll see. Maybe yeah, fingers crossed. And then it will be, you know, it will look like that. Is it possible to also store donor milk in smaller containers? Yes. The donor milk bank at WakeMed Mother's Milk Bank does 1 ounce, 3 ounce, and 8 ounce containers. I think though, and I am not sure the last time it's been a while since I've been in that milk bank. I'd have to ask Montana, but my understanding is that most hospitals are ordering 3 ounce containers. And that's generally what they're pasteurizing and shipping in. And it's been since I haven't lived in Raleigh since 2018. So at least a couple of years since I've been in their milk bank, and that could have changed. So that's definitely a possibility. But then you're also talking about workload for if you put it in larger containers and can put those in a shaking water bath all at the same time. There's only so much space, but if the container height changes, they can do more at the same time. If you're moving to 1 ounce containers, you still can only do so many containers at one time. So that is my understanding of why they don't do all small containers. And for ease once you have a full grown baby, 3 ounces is going to be what you're looking for feed. So if you're using it to supplement a kid that was, you know, at full feeding capacity, then they would need all of the 3 ounces. So it kind of makes sense clinically why it's at 3 ounces. It just ends up being waste in some NICU settings when they're not using it all. And then what does expanding university curriculum like? That is a good idea. I don't know. So the study that we're doing or working on getting out right now is really from currently certified IBCLCs, what their experience was going through their pathways for certification and what barriers they had to getting a job. And I'm really interested in a lot of people in your area, and I know NC State has classes now, but prior to those classes existing, went through the Pathway 2 program at UNC Chapel Hill. And really my thoughts about this and my collaboration that grew with a colleague was someone that went through a Pathway 3 from a peer counselor educated. And we got into a lot of this conversation about what did you actually get to see before you sat for the exam, because it's so structured in a Pathway 2 or accredited environment of you have to see XYZ before you leave. And it's not, it's supposed to be in a Pathway 3, but it's really, you know, they audit on a random basis. They can't look at every single person. And so we're really trying to identify gaps in the education. Is there a model in the US specifically? Internationally, there's not as much access to these different systems, but in the US we have access. So is there a different model that is training lactation consultants with their self-efficacy in a better manner, that they are able to go out and do things, sell themselves, have like employable skills? Does that, I mean, for those in that area, the MRTTI grads really get hired by UNC and WakeMed because they're training those students. So does this funnel easier for students that have a coordinated program? And we've seen that model work and grow across the state with North Carolina A&T and Johnson C. Smith having newly accredited programs. So that's what we're kind of interested in looking at. Is there something that's working better and getting people to be able to work in the field more consistently that they want to be working in? And I can definitely get results. We don't even have that second study, we don't even have a manuscript drafted yet. That's literally, she's like across the hall right now working on bacteria. So I can, as that comes out, I can share. Is there a cost for small versus large containers in addition to time? I wouldn't think so, because they're using the same pasteurizer on the same settings each time. So I guess you might have additional cost depending on the price of how many small containers you need to fit all that milk. But I've never gone to that level of looking at what's going on. I don't know how much the 1 ounce containers versus the 3 ounce containers cost, how many you'd need to order of them and that kind of thing.
What I was really meaning was about the idea of, if you're doing only smalls, you've got more to do. And
Yeah.
so that might mean that if you have more to do, you've got to put them in more often. And that
Yeah,
kind of
and
triples or doubles the cost to process.
yeah, definitely. And milk banks already have a hard. When I've spent my day in the milk bank, I'm like, man, you guys really, you're moving the whole day. It's always turnover in their pasteurizers. And then also thinking about it, even if that was more effective for NICU, the cost of adding more pasteurizers to try and keep the time investment the same, those are expensive. Or shaking water baths that Wake Med Mother's Milk Bank uses. So did that answer your question? Okay. And then I see in the chat how donor milk is affected by pressure. Yes. Part of my dissertation looked at pressure and heat, and we know that high pressure processing is really effective in actually even still maintaining, especially if you can do for a short amount of time and high pressure, in maintaining some of the bioactives at a better level. It's just super expensive to turn over milk banks. Right now, every milk bank set up to use Holder pasteurization. We have a lot of data on it, and these other technologies are new. Well, for human milk banking, they're a new concept, even though in food science, they're not a new concept. So that exists, but it's just not something that they utilize in a milk bank at this time. I do know that they use in Europe, they use some freeze dried models, and there's the one version of donor human milk that exists in the US, Medela milk. Nope. Yeah, I did my whole dissertation on this. Now I can't even. Medelac is the name of the company. They use pressure. So there is a model, but it's using retort processing. So it's high temperature and pressure at the same time. It's just a short amount of time of exposure. Running milk banks, that's a good question. So the milk it gets sold. So, and it is rather expensive. If your baby's staying in a NICU, it's something that's kind of rolled into the cost of being in the NICU. So for those families, it's maybe not as burdensome compared to the bill they're getting for their kiddo staying in a NICU. But in a well baby unit, if the mom is just needed as a bridge, for the mom's not making enough, or we need supplementation, that can be a barrier because it can cost, from my understanding, anywhere between $3 and $8 an ounce, which is a lot, unless it's used for a very short time. So a lot of the money comes from selling the milk to the hospitals that use it. And then the hospital associated milk banks also are integrated into the budget models with the hospital. So I have to assume there's some overlap there of what's happening if they're not profitable as a milk bank. And I guess Montana probably know more about that. And honestly, milk banks have been growing. I'm not sure that there's really a threat to having more milk banks. The only thing is that it's very possible that we don't have enough milk to go into the milk banks, because we have milk banks now. We use milk depots to get the milk to those milk banks. So other sites that, people collect all the milk, but then they ship it to the milk bank. And so, we're already shipping milk from places to the milk banks that exist. And I know at some point there was, and I think it waxes and wanes with each milk bank of if they're needing more donations or if they're overflowing with donations and things are, expiring in their freezer. But that is an interesting, I don't know any information. I don't know that they've even done any studies on what's happening there. Savannah, why are the NICU babies fed milk from a milk bank instead of pumped milk from their mothers? They are not supposed to be prioritizing pumped milk, milk bank milk over pumped milk. These are in situations where the parent's not making enough milk, or there's some sort of postpartum event, like if the baby has hypoglycemia and we need to feed, or the baby is having really high jaundice levels and we need to feed, and the mom's still making just colostrum, we might need a volume to reduce the risk of those things, developing into a scary clinical condition. So they're not supposed to be prioritizing over pumped milk. And then long-term NICU babies end up getting fed some donor milk because it can be very time intensive and difficult to maintain a milk supply when you're not with your baby and the baby's not actually feeding at the breast. So pumps are not effective for everybody. And then, for those individuals, if we can get them to hand express or use a manual pump, that might be more effective, but now it's taking an hour to pump every time instead of 20 minutes when they just, put the electric pump on. So it's a mixture of reasons, but we hope that they should be feeding the mom's milk first and then the donor milk second.
Okay, does anyone else have any questions they'd like to ask Dr. Lima? Okay, well, thank you everyone for attending this seminar. We loved having you, Dr. Lima. It was a lovely presentation for sure. And next week, we will be hearing from Dr. Karina Diaz-Rios.
Before we shut off, I'm a late comer to the seminar, but I'm sorry for being late, and I'm not surprised. I could show up at 12:20 and you could finish an hour seminar in that amount of time. Hope.
Sorry.
Some things never change.
Yep,
But
no, I'm
anyway,
a fast talker.
Yeah, I'm delighted to get to see you, and I will go back to the recording and have a look. So anyway, it's just really nice to see you, and wanted to say that.
Yeah, nice